We're going to move on. It's really my incredible pleasure to introduce Dr. Sandra Springer. Dr. Springer is professor of medicine in the Department of Internal Medicine, Section of Infectious Disease at Yale School of Medicine. She is a board-certified internist, infectious disease specialist, and addiction medicine specialist. She's an attending physician at the Veterans Administration Connecticut Healthcare System and director of the Infectious Disease Clinic at the Newington site of the VACHS. She is an appointed member of the International Antiviral Society USA, that's this group, IAS-USA Antiretroviral Guidelines Panel, as well as a core faculty member, and has been appointed to the National Academy of Sciences, Engineering, and Medicine's Committee on the Framework for the Consideration of Chronic Conditions in Women. She mentors students across disciplines, including public health, medicine, and social sciences, and her research centers on the integration of substance use and infectious diseases with a focus on opioid use treatment and the treatment and prevention of HIV infection in people with carceral experience. In 2022, she was awarded the NIDA Avant-Garde Award for her innovative proposal to bring mobile health care for substance use and infectious diseases to where people live through mobile pharmacies and clinics. She's the director of the clinical research lab InStride, which stands for Integrating Substance Use Treatment Research with Infectious Diseases for Everyone, which encompasses a multidisciplinary team, including research staff, clinicians, community health workers, and patient navigators, as well as a mobile health unit and a mobile pharmacy and clinic. Sandy, welcome.
Thank you. I'll just move this. I have to bring my own water. Thank you very much. Thanks for reading that. That was nice, and sorry. Turning to drugs, I like how they set this up to wake you guys up. We talk about sex, now we're moving to drugs. So these are my disclosures. And I want to just say it really is an honor to be here, and I'm really to be part of this amazing faculty and also to be here with all of you. So thanks for coming. The learning objectives are here. Hopefully you'll come away, if you do not know yet, how to screen and diagnose substance use disorders, and really understanding that you have a value in potentially offering treatment to your individual patients that you're seeing who have in particular opioid, alcohol, and stimulant use disorders. And then just touch briefly on the need to consider other methods besides just offering medication treatments and treatments in general for this group of individuals who use substances. So this is the outline. So I just want to start out with addressing stigma. The terms on your left are the ones we should not be using. Just like we have person-first language for individuals who have HIV is the same as individuals who use substances. So we should not be using terms like addict, junkie, alcoholic. We should not be referring to individuals based on their urine tox as clean or the individual as clean. What is the opposite? It means dirty. We don't like those terms. So we really should be using these terms. And again, person-first language, so just reminding everyone, when we refer to a test result, negative or positive, just like we do with our HIV testing results. I also want to point out that we're really proud of this, that the IAS-USA sponsored a wonderful webinar series on the MATE Act training requirements that is now complete. How many people, raise your hands, are familiar with the MATE Act? Okay, so it's Medication Access and Training Expansion. If you hold a controlled substance license or have a DEA license, or you're about to get one, you have to have at least had one time an 8-hour training on how to complete substance, or how to address opioid use disorder and other substance use disorders. So you have to identify that on your DEA license. This series does that for you. There are many options, but this one in particular offers training for individuals who have HIV and all of the substance use disorders, and there's really great ones. So I'm not going to be able to talk about how to do everything, but I would let you know, go to the IAS-USA website and you'll find all of these. They're free. You can download the slides. You can listen to us talk. So the problem, just in brief, this is from the 2022 data from SAMHSA, the National Survey Drug Use and Health Data. that over 70 million individuals who live in the United States reported illicit drug use, and about 50 million were diagnosed with a substance use disorder. Of that, about 3 million have been diagnosed with an opioid use disorder. And although you don't need a diagnosis of a substance use disorder to die of overdose, unfortunately, we've also seen dramatic increases in overdose deaths that I'll show you in a minute. But as of mid-2023, upwards of 111,000 deaths, and we know those numbers are rising. All of these numbers are underestimates, right? This is national household survey data. Individuals who live in, or who are currently existing in the criminal justice system, and those who are unhoused have much higher numbers, and we're really doing a poor job in diagnosing individuals. So just wanted to give that caveat. So this is recent, I like to show this slide. It's from Friedman and colleagues, published in Addiction in 2023, showing the epidemic, starting out with the prescription opioid epidemic in green that we're very familiar with. And then, there we go, there's a little pointer. And then quickly followed by the black tar heroin epidemic in purple in 2010, and then followed quickly by the synthetic opioid epidemic in 2013, really fueled by fentanyl that has just taken off, causing enormous morbidity. But also just want to point out our fourth wave, which is the stimulant epidemic. And on its own, stimulants can account for over 40% of overdose deaths, but obviously we're seeing this combination with fentanyl that is really just taking off. That being said, in addition to the substance use epidemic that we see in this country, we're also seeing, as you know probably in the hospital, as if you're infectious disease clinicians, seeing marked increases in bacterial infections, infectious endocarditis, septic arthritis, really paralleling these epidemics, as well as acute hepatitis C in young populations, as well as HIV outbreaks. And this is in no way complete, but just wanted to point out, since at the epidemic identified in Indiana, Scott County, Indiana, which was related to injection of a prescription opioid, oxymorphone, since that time there were multiple new HIV epidemics occurring among people who use drugs. So not just through injection drug use, but also through condomless sexual intercourse in Medicaid and non-Medicaid expansion states. And there's been several other outbreaks that I don't have here since that time. This is just a summary slide to really just represent and remind everybody. We all know that sharing injection drug use equipment, as well as having condomless sexual intercourse, among those who are using drugs as well as not, increases the risk of HIV transmission and acquisition. But among those who are living with HIV and are continuing to use drugs as well as alcohol, there's an increased risk of interfering with the HIV care cascade, and therefore leading to interruptions in antiretroviral therapy, adherence, increasing viral load, and then, of course, progression to AIDS-defining conditions and high death rates. But also from a public health standpoint, if we cannot maintain viral suppression in our individuals who are using drugs, then there's an increased risk of transmission. So we really need to think about how to identify and integrate substance use disorder assessment and treatment in these individuals if we want to meet our goals. So how do you do that? This is not anything fancy, just like you do with HIV. If we test people for HIV, we should be able to offer antiretroviral therapy. If they don't have HIV and we want to prevent, we should be able to offer PrEP. So if you have an individual who you're seeing, you should be able to assess and diagnose, hopefully, substance use disorder, and with that be able to offer treatment and prevention services for prevention of overdose, and not just initiate, but also help individuals retain and care. So the first part, identify. So this is nothing new, measurement-based care, and just like we said for HIV, we also should be doing this for substance use. In particular, talking about opioid use disorder in this particular situation from NIDA with this particular article, because we know that medication treatment for opioid use disorder, as I will just present in a little bit, does reduce death, and we should be able to diagnose and offer treatment immediately in the moment. So diagnosis, you don't need to read all these, but how do we make a diagnosis for substance use disorder? So there's not a test, there's not a biological test. We have to actually ask questions. And these are the diagnostic criteria by the DSM-5. And there are 11 criteria. In the last 12 months, all you need are 2 of the criteria, any 2. You don't need withdrawal or tolerance. Any of these 2 means you have a substance use disorder. Then it's broken down by severity, right? Mild, moderate, and severe. So 4 or more symptoms indicates one has a moderate substance use disorder. And the reason why I highlighted that is in order to prescribe medication treatments for opioid use disorder, you have to have a diagnosis of moderate to severe opioid use disorder. But not all of us know how to do that. And in fact, we know there is not any universal diagnosis occurring in our healthcare settings. I can say that. It's not happening at Yale New Haven Health System where I'm at. You can screen. There's lots of screening tools. The first 3 are for general substance use, and the last 2 are for alcohol in particular. I'm just highlighting the NIDA Quick Screen and the NIDA Assist. It's free, and it assesses all substances, including tobacco. And it just starts out with one question. All you have to ask is, in the past year, have you ever used originally prescription drugs for non-medical reasons or what they describe as illegal drugs? I don't say that. I might say heroin, fentanyl, others. If they report just once, that should lead you to doing a full assessment. So for opioid use disorder, as I said, you need to have moderate to severe opioid use disorder, so 4 or more symptoms. We had created a diagnostic tool for the DSM-4 previously called the Rapid Opioid Dependency Screen, and we decided we also needed to do one for DSM-5. So this is now an available tool to everyone. It's rapid. You get a diagnosis in less than 3 minutes, and it was validated to the DSM-5, and also importantly that non-clinicians can administer. So for me, patient navigators, community health workers, anyone can do this. And why is that important? So that you can offer treatment. We want to be able to get people into treatment quickly. Or you could refer to somebody, maybe an addiction psychiatrist, an addiction medicine person, or perhaps you know the symptoms yourself. So treatment, this is just a summary slide of the current FDA-approved medications for opioid use disorder. You can see they're broken down by their mechanism of action, how you can administer them. They're all effective at reducing opioid craving and, importantly, overdose deaths, as well as reducing HIV risk and, as I'll show you briefly, improving viral suppression rates in those who have HIV. The key things, too, are that buprenorphine, which is a partial opioid, and then extended-release naltrexone, which is an opioid antagonist, complete blocker, think of long-acting naloxone, can be prescribed in any setting, so primary care, HIV care setting. Methadone, just as you're probably aware, can only be prescribed in a licensed opioid treatment program if you're giving it once a day, so you can't until the laws are changed. And this is just a summary. I don't have time to go into all the data, but they all work, right? And the key thing is that, importantly, especially for buprenorphine, which is the most effective treatment, reduces death, but also, of course, reduces transmission of HIV and hepatitis C. And importantly, buprenorphine and methadone, because they are opioids, can treat withdrawal, opioid withdrawal, and also have analgesic effect, obviously, and can co-treat pain. So this is just a schematic of when you might want to consider individuals for these 3 different treatment regimens. The big difference is naltrexone, of course, because it is an opioid antagonist. You cannot administer that to somebody who's in opioid withdrawal, correct? And also, if somebody is having an acute pain or chronic pain condition, it may not be the option. And importantly, you need to be off of all opioids for 7 to 10 days, so it's really difficult to do in the community setting. And I just want to point out that although they're all really effective, unfortunately, if you look in all our clinical trials of treatment of medication treatments for opioid use disorder, only about half, it's really lower than that, actually retain on treatment for opioid use disorder in 6 months. And then there's data that we have, say, from the VA, real-world data that it's even much worse, 30% on treatment at 12 months. So this is traditional oral regimens, and it's important to think that we need novel methods to improve retention. So similar to how we think about long-acting CAB, relpivirine, longer regimens that will be discussed by Dr. Landovitz later. We also are thinking about that in the opioid use disorder space. So extended-release naltrexone, while it's an injection once a month, as I said, it's difficult to initiate. So buprenorphine, there's now 2 formulations available for you to prescribe and administer that are long-acting injections. They're monthly. The Brixadi is also a weekly formulation, and you can see the differences here, but really exciting. Although we don't yet know if long-acting buprenorphine is superior to daily sublingual buprenorphine. There's data to suggest that it might help individuals who have difficulty adhering or taking a daily formulation, that this would be beneficial. We're currently conducting that type of trial in the VA in 20 sites across the country, and so we'll hopefully have that data soon. And I'm not going to have time to go into all of this, but I highly encourage you to go to the IAS-USA website, the MATE Act trainings, because we actually go into detail on how to start somebody on buprenorphine, as well as there's also a presentation on using long-acting injectable buprenorphine. But I just broke this down into the reason when you see an individual who has opioid use disorder, it's really important to know what stage they're in their opioid use disorder to know when and how to start buprenorphine. So somebody who's currently using opioids and in withdrawal, super easy. Just you give them buprenorphine, and within 10 to 15, 20 minutes, they feel better. Then there's individuals who are using opioids but not in withdrawal who have opioid use disorder, right? And there's the traditional method, you wait till they're in withdrawal, then you administer. Or there's a lot of data now, and one that I use is you initiate the buprenorphine at the same time they're taking their opioids. And similarly, in the hospital, someone might be on long-acting opioids or short-acting opioids for pain control. You can initiate the buprenorphine safely. And again, go to the website and the research that has shown that that is effective. Then there's a third population that has opioid use disorder, not currently using, but is at high risk of relapse, in particular those who are coming out of prison and jail, other confined settings. You can also initiate buprenorphine in that setting, but you need to go lower and slower because it is a partial opioid. So we have to be careful with that, and there's data to support how to do that. This is how you assess withdrawal, and it's free, the clinical opioid withdrawal scale. You're probably familiar with that. The only thing that you have to do when you physically is assess the pulse. The rest is just observation, and you can see in red that you'll get the level of withdrawal. And that is important because you want to reduce withdrawal symptoms as well as reduce craving symptoms when you're treating patients. I'm not going to go into this, but this is a comparison, and it'll be in your slide deck as well as on that webinar series that I was talking to you about on how to do these different ways of inducting. And you can see initiating treatment in the traditional method, precipitated withdrawal can occur more quickly, and the other two lower overlapping buprenorphine while someone is using opioids, you're less likely to cause withdrawal. The other thing I wanted to point out is you don't need to delay initiating treatment. You don't need to do an extensive physical exam or an extensive psychiatric assessment. Really offering treatment in the moment when somebody needs it is absolutely critical. Do all of that later. And then also don't forget about STIs, other things, vaccinations, but you don't need intensive behavioral treatment. I just put this up to remind you that there are no drug-drug interactions between buprenorphine and integrase inhibitors, which are your top-line treatment. There's no reason to withhold medications for concern about interactions. And I'd also say this for hepatitis C as well. And there's data to support that when we initiate opioid use disorder treatment for individuals who have HIV, we can help them achieve the end goal, which is viral suppression, and help them maintain viral suppression. So MOUD as treatment as prevention. I won't go into the details, but this is a study showing buprenorphine that we conducted right soon after the FDA approved buprenorphine to be provided, or that could be provided by non-licensed opioid treatment programs. So we started it around 2004 and just offered buprenorphine to people with HIV coming out of prison and jail. And in green, you'll see the primary outcome was, would that improve the likelihood of achieving and maintaining viral suppression? And it did, compared to those who were not retained on buprenorphine and those who chose no buprenorphine. This then led to the quintessential double-blind, placebo-controlled randomized trial, which was utilizing the first injectable form of opioid use disorder, which was, this study was started right after it was FDA approved in the United States, extended release naltrexone, again for individuals with HIV coming out of prison and jail. And the primary outcome was achieving and maintaining viral suppression at 6 months out, and achieved that versus placebo lost viral suppression. So the idea is evaluation and improvement in adherence. Alcohol use disorders. So lethal combination, we know that alcohol use disorders are much more common in individuals with HIV compared to those who don't have HIV, increases risk behaviors, and also is associated with poor adherence to antiretroviral therapy, increased viral load, and accelerates liver disease. So as I'd mentioned before, there are screening tests that we can use. A very simple one is the NIAAA question. You just ask, do you drink alcohol, wine, or beer? If yes, how many times in the past year have you had, for women, 4 or more drinks, or 5 or more drinks for men, in one day? If yes, then that would then lead you to doing a full assessment. Here is a very simple one, Audit C, which is only 3 questions. There's also the full audit. You get a score, and it tells you for men and women where you should be considering an alcohol use disorder. And I just put this slide up to remind you that it's not just about medications, and it's also not just about abstinence. So there's a lot of data for individuals with alcohol use disorders that doesn't have to be abstinence. For some, absolutely, that is their goal. Others is what we call reducing to low risk drinking. So that's something important to know, and what their goals might be. And then it's really important to identify if they've ever had a history of severe alcohol withdrawal, right? Because if they have, then you don't want to be initiating treatment in the outpatient setting, because we don't want them to die from alcohol withdrawal. So that would be an individual that we'd have to admit. And there's lots of other behavioral treatments that have been very effective, including 12-step programs. So these are the current FDA-approved medications for alcohol use disorder. You'll see that we have naltrexone and extended-release naltrexone in the red box. Just to point out, which I didn't say in the slide on the opioid use disorder, oral naltrexone is not effective in opioid use disorder. However, it is effective for alcohol use disorder, as is extended-release naltrexone. So really important, and you don't have to wait for someone to stop drinking. You can initiate these treatments while they're drinking. Again, just make sure they haven't had severe withdrawal symptoms in the past. And I've published on this and others. There's no increase in liver toxicity or anything else. It does decrease the craving, which is really important. And similar to the opioid use disorder studies, we also conducted a similar trial as the other one that I mentioned, where we did a double-blind placebo-controlled trial looking at, does the impact of extended-release naltrexone given monthly improve viral suppression rates, again, for people with HIV. And sure enough, at the 6-month time point, improvements in viral suppression compared to placebo. Stimulant use disorders. So amazing talk on that, and this is free, by the way, I'm not getting anything for this, but on the IAS-USA website under the MATE Act, there's a spectacular talk by Dr. Stephen Shoptaw at UCLA on treatment of stimulant use disorders, including how to do contingency management. So I'm not going to go into that right now, but we have cocaine use disorder and amphetamine type stimulant use disorder, ATS. We also created, you could do the NIDA Assist or whatever it is, the NIDA Quick Screen to assess for stimulant use disorder, then do assessment with the DSM-5. We also created a rapid diagnostic tool for moderate to severe stimulant use disorder that was validated to the DSM-5 and also for non-clinicians, just to let you know. So there are, unfortunately, is not any FDA effective medication, FDA approved medications for stimulant use disorder yet. So I did mention contingency management, and I don't have time to go into all of it, but it is the most effective form of treatment for stimulant use disorder, without a doubt, hands down. So incentives to help reduce stimulant use. It could be monetary, it could be other goals, and they're done successfully in HIV and primary care settings, substance use settings, so a very, very effective method. That being said, although there's no FDA-approved medications for stimulant use disorder, I do want to point out, and it will be in your slides as well, that American Society of Addiction Medicine and addiction psychiatry organizations put together this lovely clinical practice guideline on management of stimulant use disorders. It discusses contingency management, of course, but they do have guidelines on, even though medications aren't FDA approved, their recommendations on maybe individuals you might want to consider some of the forms of treatment that are mentioned here. So for cocaine use disorder, bupropion and topiramate, and then for amphetamine type stimulant use disorder, the combination of bupropion and extended release naltrexone and mirtazapine and topiramate. So I just put that there for your reference, so you can look at that. Always, 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 no matter whether they have a substance use disorder, if they're reporting substance use, always offer harm reduction tools. So this is a picture I took in DC, which I loved, you can go and select clean injection works, as well as naloxone, condoms, everything. It was awesome. But we should be offering, or be aware, I know in Texas it's illegal. Syringes are illegal, but there are places that do offer. But clean injection works, as well as safe injection sites are very effective if you have those. And then for those who are concerned about testing their drugs, for concerns about fentanyl as well as now xylazine, there are test strips that you can offer patients to test their drugs. Everyone probably knows this, there's really not any heroin. There's some heroin on the street, and even when people are reporting they're using heroin, it's really fentanyl. But those who are using stimulants, there's a lot of, as I mentioned before, fentanyl in the stimulant supply as well. So that, and then xylazine, unfortunately, naloxone doesn't work, right? So it's for some individuals, for them to know that xylazine's in the drug supply can be very helpful. And then I always talk about people, if they're going to use, try to use slowly, try not to be alone, and have somebody who's also trained in how to give naloxone. And I just want to end with something here, that we have to remember that individuals who use substances have substantial amount of barriers, including lack of transportation, which is absolutely critical, urban and rural settings. I live in Connecticut. There is a non-existent public transportation system, except maybe in New Haven and Hartford, but elsewhere, very difficult. Housing instability impacts treatment, poverty, lack of insurance, and a lack of personal identification, very common in individuals who are coming out of the criminal justice setting, as well as our unhoused population. You cannot go to a methadone program without a form of an ID. You cannot go to a commercial laboratory like Quest without a form of personal ID. So if you're thinking about repeat testing for HIV prevention, other things, you need to help individuals get a form of ID, and this population really needs help. Mental illness, and something that, as Dr. Landovitz described, we've been focusing on is bringing pharmacies to patients so they can't maybe come to us, and we've done data, we've looked at that. There's a lot of stigma, obviously, and really just navigating. Where do you even start? How do you do all of this? So really having support for individuals. So just thinking about low barrier access to services, there's a lot of data supporting in resource limited settings, as well as in the United States. Community health workers can be very helpful going to people, not expecting people to come to us in our traditional, brick and mortar clinics. This is our mobile pharmacy in the little picture down there. It's the first in the United States, the first legalized mobile retail pharmacy. I did not know when I got the award that they were not legal, so we had to pass legislation in Connecticut. So Connecticut has the first mobile retail pharmacy. Anyways, it's also considered a specialty pharmacy, carries all forms of injectable medications, vaccines, everything. So that's being evaluated now. And I really think we need to be considering long-acting PrEP and long-acting antiretroviral therapy in this population. And Dr. Landovitz is going to talk about a really exciting couple of trials that came out at CROI. I'm leaving that to him. And really also Dr. Sachs and the rest of the group, recent paper in JAMA that discussed the use of treatment who have adherence concerns. So everything that I just said is in the 2022 IAS-USA guidelines. We are very happy, and thank you for the first time of offering substance use disorder recommendations, and everything I said is in those. And so I also just want to end with this warm line, just to put this in your phone. You can call, it's UCSF, and if you have any questions, they will get back to you and can help you talk through how to treat substance use disorders in your individuals. So thank you.
Thanks, Sandy. That was really terrific. I think many HIV and primary care providers struggle with comfortability about how to approach these kinds of problems. So the practical information you provide is so helpful. So thank you for that. Got a bunch of questions from the audience, and again, microphones are open, so please don't be shy. Come down. We promise we don't bite. You at the end alluded to your endorsement of the use of long-acting treatment and long-acting PrEP with injectable naltrexone or with long-acting substance use treatment. Do we actually have a lot of experience with it, and what are you doing?
Yeah, so there hasn't been a trial, as you indicated, and Rafi, that has looked at that has looked at the combination, acceptability, feasibility of providing injectable, say, buprenorphine with injectable PrEP or ART, which I would love to do. But we do have anecdotal data to support, especially another study that we're doing, which is comparing mobile health unit provision of care and access to PrEP, ART, Hep C, MOUD, compared to patient navigators with bringing people to traditional clinics for people who use drugs. That there's a high interest in long-acting forms of PrEP and ART for individuals who are at risk or living with HIV. And we've successfully been able to provide that to them, including bringing and administering, and now on the pharmacy, long-acting PrEP and ART to those individuals, as well as injectable buprenorphine more so. So it all comes down to assessing what somebody is really interested in, and we do see our population who's unhoused, who has adherence challenges, those coming out of prison and jail, where there's a lot of barriers that the acceptance for these long-acting forms of treatment is high and can really help individuals. So my stance is we should be offering people choice, and you're going to be talking about some of that data, so I didn't do that, but I can't wait until you present it.
We love choice options.
Yep.
You had mentioned that there was no increase in liver toxicity with naltrexone.
Yep.
Someone in the audience had in their mind that you had to check baseline LFTs before starting. Is that not true?
Nope, nope. You don't need to do LFTs, you don't need to do an EKG, you don't need to do any of that. So that's not just me saying that, but we've done publications, as have many others, showing the safety of extended release naltrexone. Individuals who have HIV, as well as those who have hepatitis C that has not been treated, and among those who are continuing to drink alcohol as well as use opioids. Very safe. You might see a fluctuation, a slight increase, especially when individuals, say, who are drinking might increase, but they all come down to lower levels. So the recommendations of the American Society of Addiction Medicine, ASAM, treatment guidelines for opioid use disorder, also including extended release naltrexone, say that you do not need to start with baseline LFTs. Same is true for Sublocade, which is the injectable form of buprenorphine. You don't need an EKG, which was a huge hassle, and you don't need LFTs either. But
Great.
we should be checking those things and assessing for hepatitis C and B, et cetera, too.
Excellent. Question here.
Thank you so much for your talk. I had a question about how you would approach people who've successfully achieved some of their pre-treatment goals, such as remission of their alcohol or substance use. They've gone back to work or school. They've become parents, and they feel the need to either stop using or continuing Sublocade or Suboxone or other treatment or programs because they feel that they either don't want it, don't need it. I just was curious how you frame that for them going forward.
No, it's a great question. And we do see this often, and Dr. Abrams was reminding me last night, about individuals who are pregnant and postpartum. We often, unfortunately, see that's a time when women stop, unfortunately, treatment with buprenorphine, and is also the highest risk and increased overdose. But what I do is I try to remind individuals, one, there's no evidence that continuing treatment, methadone, buprenorphine, whatever, is hazardous to your health, like for years. We don't know how long. I always say we should continue treatment for as long as an individual needs that. But there's a key thing I always talk about with patients is relapse is common, right? It's a continuing process, and that I help them by, just like we used to do with the pain question, 1 to 10, what level of pain are you in? I do that with craving. So craving is well known to increase risk of substance use. In a scale of 1 to 10, we talk about where their level is every time they're with me, and we talk about what their level of craving had been when they were using. And if they start seeing a spike in that craving, that is someone that is at high risk of relapse, and to consider, contacting whoever it is that you're working with to initiate treatment. So I counsel patients how wonderful they're doing if they're in that space of the patient that you just described, and saying, also reminding, do they have ways of coping, or how can they manage life when whatever it is that is stressful for them or might have increased craving is going to occur? How would we address that? And there's no shame in if they do want to stop treatment at that moment, if they want to restart at any time. But I have a open discussion with people, and you can't force people to stay in treatment, but I just remind them of the great things that have happened while they've been in treatment.
Great. So 3 quick questions about operationalizing buprenorphine administration. Covered by ADAP or PrEP app, what are the minimum set of clinical supports you need in place in a clinic to do it, and are you concerned about diversion?
No, okay, yeah. Last one, no.
That's easy.
So I don't have time to go into all of it, but again, I'm referring you guys can actually watch it now. There's a talk by Dr. Leish on the webinar that talks about how to actually, the practicalities on how to initiate buprenorphine in different settings. And then there's also one on initiating injectable buprenorphine by Dr. Loftwell from University of Kentucky. But yeah, no, it's the basic things. I think this is the big issue, right? There's this fear of precipitating withdrawal. That's what I hear from people and why they don't want to do it. But let me tell you, what is the opposite if you didn't offer treatment? The fear should be that that patient's going to die. And that is actually what we see of any potential use. So the minimal things are, hey, you guys do HIV, man. You guys are you can do this. Buprenorphine is not, treatment is not scary. And it's one of the best things you can see is somebody reducing their withdrawal and not craving. But the basic things are just, I would say probably in your clinic setting is having support from your staff, your nursing staff, making sure they're talking to their patients if they know how to get a hold of you. Being able to start somebody on buprenorphine, there's home induction models, but you might want to have support staff that can help you talk to that patient population. And then we just do basic stuff. Again, this is on the American Society of Addiction Medicine, SAMHSA websites, et cetera, how to initiate. You could have a discussion with your staff on how to help somebody who is craving and getting in touch with you. But really just, there's not a lot that's needed. We're doing this via telehealth. We're doing this, many are doing this on the street, offering treatment in the moment. It's just really counseling individuals about withdrawal and craving and what to do. Yeah.
Great. So unfortunately, we are out of time. So again, if you have questions for Dr. Springer, please come find her at the break. Super, super quick, Sandy.
Oh.
People had questions about marijuana treatment and GHB treatment. Are there medications? Rapid fire round.
Yeah, I don't know about GHB, but there's that this is discussed in the guidelines, but there's not currently FDA-approved medications yet for either of those, and I don't have particular recommendations, unfortunately. So.
Okay.
Yeah.
Thank you very much.